Now I'll be discussing about pneumonia. Well, question number 1. Which the following is the least useful for assessing for poor prognosis in a community-acquired pneumonia? Community-acquired pneumonia. The answer to this question is C, reactive protein or 154. Why this the answer? Why not others? This you will never understand unless we know the basic concept about how to approach a case of community-acquired pneumonia. Well, C-reactive protein is not a criteria of severity. Other options are, this is about the other part of curb 65 score. This is C for confusion, mental score to know about confusion. Urea is U. Respiratory rate is R. And age is 65 years. So all other four are the part of curve 65 score. And what is the curve 65 score? Which is a criteria of to know about severity of the disease. I'll be talking in much more detail just now, but as of now we have ruled out why the C-reactive protein is not a answer, or not the is the answer, and it's not a part of curve 65 score. Okay, the rest all are the part of curve 65 score. So friend, the only key word to remember is curve 65 score. Note it down, and I'm going to discuss in great detail just now. So now he says, beautiful question, not known to 99%. What is that beautiful question? Patient has come to you in your emergency. You are attending physician. So primary care setting, note it down this word. What the meaning of primary setting, and soon I'll be talking about primary care, secondary care also. Okay, this is something very tricky. So nice guidelines recommend that patient should be initially assessed in form of CRB65 criteria. Point to be noted, this is CRB65. It's not a typing error. U is missing. I'm sure most of you are listening for the first time. So what is that? So first I tell you again, C for confusion, and that we know by mental test score, if 8 or less than 8, confusion. R for respiratory rate more than or equal to 30. BP systolic below 90 and or diastolic below 60 and above age is 65. So they are the keywords are, the keyword is 8 by 10, more than 30, 90, 60 and 65. But definitely you are going to ask me a question, so why we have not used U as the part? Yes, that's the trick. So whenever you get a question like this, what he says, patient has come to you in emergency. Let's presume that you are seeing a case of emergency, and you can see confusion level, you can check the respiratory rate, it is obvious, you can check the BP and age, you know. This you can do within 1 minute or 2 minutes of arrival of the patient. So we got the criteria of CRB65, but we have not sent the blood sample. Blood sample is yet to be sent, and urea, U for urea value is yet to get. That's why the word, what the nice guideline is, primary care setting means patient has just arrived, and at a glance, in 2 minutes only, you have to decide how much is the severity of the score. So we are using CRB. So point to be noted that in the exam they'll ask you, patient has just come to you. So they will say we can use all except. In that except, U will be the answer. In primary setting, U is not a part. Got it? Yeah. After that, okay, after that, once the patient is there, so we have to stratify. You got 4 criteria, C, R, B, and 65. Each is given 1 mark. Each criteria is given 1 mark. If score is 0, low risk, mortality risk is 1%. 1 to 2, intermediate, mortality is 1 to 10%. 3 or 4, very high, more than 10% mortality is there. So that's why the NICE guidelines say the moment patient comes, decide CRB 65, give 1 mark to each, 1 mark to each, and accordingly how much score is there, you decide about the severity of disease. Okay. So what he says, the CRB 65 score is 0, then you can very well tell the patient, okay, you can go home and you can do the treatment at home, and you have to give OPD based treatment. So 0 is OPD based treatment, and if score is between 2 or more, then patient need to be hospitalized. 2 or more, the patient need to be hospitalized. Okay, so we are clear about it, that we have to, and then once we plan for hospitalization, so definitely you like to investigate and you like to go for the urea test also. So now one more thing, lovely question, beautiful question. Again a new concept for most of students, point of care CRP test. In the option, one test which we are not useful is C reactive protein. Okay, C reactive protein is not a criteria of severity, but CRP is getting lot of importance, and then this is absolutely new concept. So first I'll tell you what is point of care CRP test, or they also write like CRP test at the point of care. Point of care. So first of all, let us see what this criteria is, then what are the guidelines as given by the NICE. So why this concept came, particularly in Southeast Asia. Antibiotic prescription for febrile patient is very common. Patient go to the primary physician, fever, and antibiotic are given written right and left. Okay, there's no check. And the disadvantage of that, because every physician is writing for a fever, there can be 1,000 of causes the fever is there. If 1,000 people are given antibiotic daily, they are bound to have antimicrobial resistance, right? But how does a doctor know whether I have to give antibiotic or not? Okay, doctors are not magician, and diagnosis is not written on the patient head. So what the medical guidelines is that you go the test for CRP testing, C reactive protein. The primary treating physician, so-called point of care. Point of care means the doctor who sees the patient for the first time. He should get CRP done. Okay, so go for CRP testing, and how we are going to make use of this CRP, this I'm going to discuss in the coming slide. So as of now, the key word to be remembered in this so-called CRP point of care, that because of unnecessary use of antibiotic, this can lead to resistance. So we should not give antibiotic to all febrile patients. So you go for checking of CRP. At the point of care, that means the first time, the doctor who is seeing the patient for the first time with fever, he should get the CRP testing done. After that, what to move? Now let us see Now, having learned the basic concept, NICE also mentions point of care CRP test. NICE guidelines has given. So what they say, now they say you have done the CRP level, treating physician got the CRP level, done. If CRP level is below 20 milligram per liter, don't use antibiotic. Clear cut. Because CRP is rises only when the inflammatory process is there. Between 20 to 100 milligram, we can wait for some time or before starting antibiotic. But if more than 100, you must give antibiotic. So lovely use of CRP, although it does not tell you, remember, CRP level does not tell you the severity of disease, but it definitely tells you the indication of using antibiotic. There's a golden line to remember about CRP. Write it down as a golden line. The CRP does not tell you the severity of disease, but it definitely tells you the indication of using antibiotic. Okay. Well, now secondary care setting, we have seen the patient and we decided, okay, secondary care, patient has been hospitalized, and other than the CRB 65, we also do urea. If it is more than 7 millimole per liter, that again is getting 1 point. So now confusion, urea, R, B and 65. Now there are 5 points. Initially there were 4 points. My raised level of urea is again a point, but which is getting 1 more extra point to know about the severity of the disease. Now, what are the NICE guidelines? Okay, so the NICE guideline recommend that if score is between 0 to 1, home-based treatment. And if the score is between 2 or more, use hospital-based treatment. But if the score is 3 or more, use intensive care. Point to be noted, even though they have classified into 3 categories. In fact, in actual practice, they always use CRB 65 score. So 0 means home treatment, 1 up to 2. 1 or 2 go for the hospital base in the ward, and 3 or more is what we need is intensive care. Because mortality is 15%, 3-5, and it is up to less than 3%. So scores 0 to 1, mortality rate is less than 3%. Score 2, it is 3 to 10%. 3 or more than 3, more than 10%. It's a beautiful summary, golden line to remember regarding CRB, CRUB 65 score and the mortality chances percentage. Now we learned about the CRB 65 and CURB curve 65, both we learned, primary and secondary setting. So let's learn. You are getting a case of suspected case of pneumonia. How to proceed? Chest X-ray. Okay. So chest X-ray has to be done. In addition to that, NICE guidelines say blood, sputum culture, pneumococcal Legionella urinary antigen for Legionella also. CRP monitoring should be done to help response to treatment. Now, point to be noted. CRP, we are also seeing to response to treatment. Definitely, if you are using antibiotic, the CRP level is going down. So that means patient is getting benefit from the treatment. But CRP is rising, that means the antibiotic are not effective. The investigation is complete blood count, chest X-ray, sputum, blood culture, and of course CRP level also. This as per NICE guidelines, how to investigate. Now how to manage? This is known to all of you, nothing special about it. Nothing special. This is a routine thing that you have been doing in your clinics and OPD also. But now this is important. This is important from exam point of view. How low severity? How do you know severity? By curve 65 score. So we plan to, maybe we want to do OPD treatment, give amoxicillin the first line treatment is a drug of choice. So as per NICE guidelines, patient having low curve score, use amoxicillin. If the patient is allergic to penicillin, then you can use macrolide or tetracycline. Macrolide means you can use maybe clarithromycin or tetracycline. Okay. Well, for how long? 5 days. NICE guidelines say that, so friends, low dose amoxi for 5 days. If your patient is allergic to amoxi, then we can give macrolide or tetracycline. Or this is summary of what is to be done for a OPD case, right? Amoxi, macrolide or tetracycline, right? Now patient has moderate or severe pneumonias. How do you know? Again, the curve 65 score. Now you have to give 2 antibiotics, amoxi and macrolide. Let's go back. So now he says use 2 antibiotics, amoxi plus macrolide. And the 7 to 10 days course, here it was 5 days course. Point to be noted, the difference between the mild case and the severe case, we are giving double antibiotic and duration is almost double. It was 5, now up to 10 days. Okay. Now what is also says that, not only that we are giving this, NICE guideline also suggests that we can consider, if you don't want to give amoxi or patient is very critically ill, then we can even go for the other antibiotic like beta-lactamase stable penicillin, like co-amoxiclav or ceftriaxone or piperacin with tazobactam or a macrolide. So this can be done. Okay. So friend, what he says, either you can go for co-amoxiclav or ceftriaxone with tazobactam plus macrolide. So now that means the only thing what we have done is we have changed this to a higher one. Instead of amoxicillin, we have used co-amoxiclav or ceftriaxone with tazobactam or piperacin with tazobactam plus macrolide has to be continued. So this is double and duration is 7 to 10 days. Now patient is all right, you planning to discharge. What are the NICE guidelines? NICE guidelines to at a time of discharge to the patient. Okay. So patient NICE guidelines say that you are planning to discharge provided in the last 24 hours they have 2 or more than 2 findings are there, then you don't discharge the patient. What are the findings? So not discharge if in the 24 hour 2 or more than 2 findings are there. Temperature more than 37.5 degree, don't discharge. Respiratory rate more than 24, don't discharge. Heart rate more than 100, don't discharge. Systolic BP below 90, saturation under 90%, don't discharge. Confusion still persists or inability to eat without assistance. So friends, the feature which indicate that don't discharge, number 1, fever, 37°5, 24, respiratory rate, heart rate 100, systolic BP below 90, saturation below 90, abnormal mental status, and can't eat without assistance. So the key word to be remember are 37.5, 24, 100, below 90, below 90%, confusion, and unable to eat, unable to eat. This is summary. Temperature, respiratory rate, pulse, systolic BP, oxygen saturation, confusion, and unable to eat without assistance. These, if any 2 or more than 2 are there, then don't discharge the patient. Okay. Not only that, NICE also recommend that when you are discharging the patient, you must give following information. That means even after discharge also, that you need to give certain instruction. So the instruction that you will give that yes, we are discharging you. Maybe the patient has very mild fever, maybe 37.2 or 3 or 4. Okay, we are discharging, but this will resolve in 1 week time, so don't worry. Chest pain will be go by 4 weeks. Point to be noted. Cough, breathlessness, 6 weeks. Most symptom by 3 months except fatigue. And 6 months the patient will be perfectly all right. It means what? The question is asked to you, by what time patient will be back to normal? The answer is 6 months. Back to normal is 6 months, otherwise most symptom will resolve by 3 months. So they are 2 different things. Complete recovery is 6 months and most symptom will go by 3 months. Fever will be 1 week. Pain, chest, sputum for 4 weeks, and cough, breathless for 6 weeks. This you have to tell the patient as per NICE guidelines. Finally, golden line to remember, curve 65 score is the indicator of poor prognosis in case of community acquired pneumonia. Question 2. A 74-year-old man, confusion, right lower lobe pneumonia on chest X-ray. 36 is the respiratory rate, pulse 90, BP is 166/48, urea is 12. The curve 12 score is how much? Is the score. Okay. So if you look into the finding, okay, it's a very simple but very frequently asked question. Let's see. So in curve 65 we have a confusion, urea, respiratory rate, BP, and age, and there are 5 points. Let's see what are the points in our patient. He has confusion, score 1. Urea is more than 7, 1. Respiratory rate is more than 31. Diastolic BP is 48, which is less than 61. And age is above 65. So this confusion is 1 score. Respiratory rate, urea is 12, 1 more. This CUR more than 30. Okay. Then with BP, this diastolic BP is below 60, 1. and finally the age is 74.1. So this is so-called, the score of this score is 5. So what does this mean? The patient is critically ill and that should be hospitalized in the intensive care. A 65-year-old admitted with fever and dyspnea, extensive shadowing in the right lower lobe. Which of the following is a poor prognostic feature? Systolic BP below 65? No, it should be below 60. Sodium is not a part of curve 65. WBC count is not a part of curve 65. Respiratory rate is 25, it should be more than 30. Urea is more, yes, this is more than 7. Hence, the best answer of this question is C. It's a simple question. If you know the basic concept, and remember, MRCP people are very fond of asking question based on curve 65 score. So if you know the basic concept and the values, you will never commit any mistake. Thank you very much. God bless all of you.